many a times the astute physician will be very keen on up titration of the dose, and he will think that okay, the paradigm heart failure trial was done at a dose of 200 milligrams twice daily of ARNI, and I should also try to achieve that dose of 200 milligrams twice daily of the ARNI. But many a times he will fail to achieve that dose because of number of side effects or number of factors which will hamper the up titration of the ARNI. So in that situation, what are the factors that will inhibit the up titration of the ARNI? We'll have a look at that. And the second thing, if we fail to achieve the up titration of the ARNI, does that impact the clinical outcome? Is it such a bad thing that we cannot up titrate the dose of the ARNI? So the first part I'll answer, why can't we up titrate the ARNI dose in all the cases? The biggest hampering factor or the biggest inhibiting factor which prevents the up titration of the ARNI is probably hypotension. Many a times the hypotension is the commonest reason because of which the physician or the cardiologist cannot up titrate the dose of the ARNI. The other common cause could be a worsening of the eGFR. You start the ARNI and the creatinine level goes up and the eGFR comes down. That could be a second important reason. And the third could be hyperkalaemia. So that could be also an important reason for not up titrating the dose of the ARNI. Now you can tackle this very easily. I shall come to more details about how you tackle the drug induced hypotension in the later part of this talk. But as far as hyperkalemia is concerned, you can easily tackle the hyperkalemia by asking the patient to avoid a lot of citrus foods, and if the potassium continues to be high and it prevents your up titration, you can easily control it by using potassium binding resins like K-bind resins, which can easily bring down the potassium level, and high potassium level should not be an impediment to increasing the dose of ARNI. As far as renal deterioration is concerned, if the creatinine level does not rise by more than 30%, then there is no worry, there is no alarm that you should not up titrate the ARNI. Many a times the creatinine level initially shoots up by 10 or 20%, and by few days or few weeks it comes back to the normal. In that case, you can easily up titrate the dose even further. If the creatinine level goes up by more than 30%, then you may have to stop the ARNI for a small while. You have to go back to a lower dose, and once again you can try up titration in a gradually slow manner, and maybe the patient will tolerate the up titration. And if your patient is not tolerating the higher dose, you are concerned that whether that I am not giving the full dose of the ARNI, will it still benefit the patient? So the answer again comes from the paradigm heart failure trial. In the paradigm heart failure trial, the lower doses of the sacubitril valsartan in patients who could not be up titrated were compared to the lower doses of enalapril, and at comparative doses of enalapril and sacubitril valsartan, the benefit was always on the sacubitril valsartan side. So if your patient does not tolerate higher dose of sacubitril valsartan and higher dose of enalapril, and you are forced to give either a low dose of enalapril or low dose of sacubitril valsartan, then you should always prefer sacubitril valsartan even in such case, because even at low dose, sacubitril valsartan is better than enalapril low dose. And therefore, even if your patient is not able to achieve the full dose of sacubitril valsartan, do not get disheartened. Your patient will still achieve a significant benefit in his cardiovascular outcomes and heart failure hospitalization, even if you are not able to up titrate that dose. And coming to the main reason of not being able to up titrate, that is the hypotension. What do we do to prevent the drug induced hypotension? To prevent drug induced hypotension, first ensure that your patient is not over dehydrated. Check the fluid volume status of the patient, whether you are over diuresing the patient or the patient is too much fluid restricted. Correct that. Do not overload the patient, but do not over dehydrate the patient. In that case, just by correcting the fluid volume of the patient, your patient may be able to tolerate the ARNI. Now many a times your patient will be on unnecessary medications. He may be on nitrates, he may be on drugs like nicorandil, he may be on drugs like furosemide. Now these drugs, they improve the symptomatology of the patient to some extent, but these are not life-saving drugs. These bring down the blood pressure of the patient, and these hinder in the up titration of the ARNI. In such a situation, make space for the ARNI. Take out all the unnecessary drugs like the nicorandil, like the nitrates or like the diuretics, and make space for the ARNI. Many a times by stopping these drugs, you can easily uptitrate the ARNI. Now, if your patient is still not being able to tolerate the ARNI dose, then go very slow. The mantra, as I said, is go low, start low and go slow. So very many a times it takes a few weeks or few months for the uptitration of the ARNI. And if you are patient enough and you can follow up the patient regularly, and once the BP is showing slight improvement after a low dose of the ARNI, you can try to increase the ARNI in a subsequent visit.